Our last speaker is Dr. Weber. Dr. Weber holds a private orthodontic practice in Ludwigshafen, Germany, and it's co-authored by a few more people from Germany. The title of the presentation is High Frequency of Temporomandibular Joint Isolated Juvenile Idiopathic Arthritis in Children with Orthodontic Treatment Need. Dr. Weber.
Dear chairpersons, dear colleagues, Merhaba Istanbul. In the next few minutes, I will try to take you here from the heart of Istanbul to another orbit of thinking. To be able to do so, I will focus on a topic which is yet not in our daily routine as orthodontists. This is juvenile idiopathic arthritis. This leads us to a planet called rheumatology. There we find another group of specialists similar to ours. But are our rheumatologists specialized in kids? I don't think so. In Germany, there is just a small group of rheumatologists, like 10 or 20. And the next question is, are these rheumatologists specialized in diagnosing or in treating patients? As their main job seems to be treating patients, let's have a closer look with our scanning satellites where the diagnosis of JIA is coming from. Pain is a leading symptom sometimes. Dysfunction of joint. Bad numbers out of blood samples. Bad signs in ultrasonic pictures. Obvious inflammation like uveitis, and of course bad signs in MRIs. Furthermore, there are gross disturbances like asymmetries, bad body movement, and some parents report foot selection. Is this all detected by the patient, the parents, or the rheumatologist? Yes, sometimes, but not always. So which group of colleagues is transporting and delivering the JIA kids to Planet Rheumatology? It's the family doctor, of course, the pediatrician, orthopedists, maybe the leading eye of the inflamed eye of uveitis. Maybe symptoms occur during therapies. But what about the orthodontist? Are we delivering or are we taking patients? Are we co-therapists for the rheumatologists? Or are we the first ones to diagnose JIA? To answer that question, we leave Planet Rheumatology and switch to a planet called Orthodontics and endofacial orthopedics. Here we are in our field of teeth, jaws and joints of the head. Do we find symptoms in our daily work like orofacial pain? Children rarely mourn, says child rheumatologist Traudl Sauermann from Zurich, Switzerland. So pain might not be a good indicator for us. Food selection, especially refusing to eat hard stuff, is something more we could be able to find in our daily work. But are we talking about the daily with our patients? Dysfunction of temporomandibular joints, do we check that? Is that something to worry about? Or is there a close moon to our planet ortho, probably called juvenile CMD or TMD? Let's have a look at early research. Signs of inflammation or similar occur in 20 to 40% of children with orthodontic treatment need. But are there JIAs amongst them? And if yes, how many? To do a first surface screening on this question, we wanted to send somebody to the service of our Moon Juvenile CMD. The first ones to screen patients with orthodontic treatment need are we as orthodontists, of course, like me and my wife, which is with me here today. So we screened 1,024 children before they went into ortho treatment. These children were not older than 16 years of age. We looked for function or dysfunction of head structures, and therefore we used an analysis developed in Kiel, Germany, called Manual Structural Analysis, or MSA. When we find data telling us that there might be something underneath the surface, we call our second team in the orbit of juvenile CMD. He uses deep scanning methods known as MRI. In this study, this was Dominik Weber from Frankfurt, Germany. Out of our MSR screening resulted 162 TMJs, all were contrast enhanced to detect inflammation. All data was blinded, no patient history or clinical information came with the pictures. As we sought to look for typical GIA destructions, we called our third team into space. This is child dermatologist Nikolai Cherbachev from Bad Braunstedt, near Hamburg. He joined us for looking for typical signs of rheumatology on the MRIs. For finding destructions, we look for variations of synovia like effusions, contrast enhancement, and hypertrophy. And for variations of bone like bone marrow edema, condylar flattening, condylar aeration. The first step to get results was the question, did we look at the same moon? Maybe from different directions, but the same moon. So intermediate reliability was statistically checked. The number for the cone cover was 0.77. As results, we independently found 10 joints out of 9 patients, and that's an amazing amount of 0.88% with signs of JIA. So what does that mean for daily life for an orthodontist? If you get a prevalence of GIA, lowest 1 out of 100,000 or 1 out of 10,000, like Wikipedia is telling us, that would affect us very much. If it's 1 out of 1,000, like Traudl Zaunermann from Zurich published, it's getting closer. But if it's almost 1 out of 100, we will definitely deal daily with 1 JIA patient in our daily life. After finding 10 temporomandibular joints, we called our friends from Planet Rheumatology for further help. And Nikolai did full body screenings, where the TMJs, the only affected joints. Our TMJ-JIA patients who started as ortho cases with some dysfunction, we ended up with oligo or polyarthritis patients. And they had hips, knees also affected, or even other joints. Final question, is our MRI a gold standard then? No, we don't think so. It is not a final yes or no switch you can turn on off for diagnosing JIA. It's a fundamental diagnostic tool, and to find and diagnose JIA, it's very good. But you also need clinical findings and other tools in addition. Maybe in the near future we have screening of genes to get closer, as I learned today. So if you're working interstellar on JIA, you need a good network, like we have in Eurojoint. This is a European group focusing on JIA and TMJ problems. So as a conclusion, we can state that we didn't expect that it's that much like 1 out of 100. That means that there might be more JIAs in ortho cases than we thought, or there might be even more in total populations than we thought. Nevertheless, it means we should screen and scan our patients properly and find these JIA patients. So the short take-home message is, look for obvious signs like avoiding eating hard food, do your screening properly, and expect that kids describe pain in another way than adults. For any questions, contact me at info@zahnspangen.de. Finally, I want to thank Istanbul for giving us such a nice meeting, and I want to thank my team at home who helped me to acquire all the data. Thank you very much.